So I'm very pleased to welcome Stefano Bertozzi.
Thank you very much. So Harley tells me that these have a tradition of being informal, and I hope that you guys respect that tradition. Because what I want to do today is to share some observations about heterogeneity related to health in Latin America. And I'm going to show you a bunch of numbers, or at least graphical representation of numbers. But I would love for you guys to be interrupting as we go, offering ideas about what are the underlying mechanisms that are leading to the kind of heterogeneity that we observe. So I'm assuming this is a very multidisciplinary, multi-background kind of a crowd. And so I'm hoping we can have a rich discussion that shouldn't wait until I finish. It should happen during, because I'm going to bounce around to various things. Valdemar Diaz is there, and he helped a lot with some of the analyses here, especially at the later part, and to pull some of this together. So I'm very grateful for that. So just to start with something everybody here, I'm sure, knows well, and that is that there's a strong relationship between health, or in this case, illness, and wealth. So this is PPP, constant dollars on the bottom in income, and this is under 5 mortality of children on the vertical axis. These are both log scales, and you see this really nice relationship. In yellow is Latin America, and I'm going to show it to you bigger in just a minute here. But you can see that Latin America spans from Haiti here to the best performing Canada here, or the richest, the US there, with everything in between. Brazil and Mexico overlap each other there in the middle. Blue is Africa, red is Asia. The two big ones are obviously India and China. The size of the bubble is the total population in the country. So I'm going to come back to that in a second. But a couple of caveats. The first caveat, this is a graph of, again, income. This is GNI per person. And this is the estimated coverage of the civil registration system in the country. And this is just a way of saying one important caveat when we're looking at data like this is that the poorer the country, the less likely you have all the data, right? So you've got to ask yourself always, well, what is the bias that is likely to introduce in the thing that I'm looking at? Is it that I don't have the data so I'm missing the good, or I don't have the data so I'm missing the bad? So if we were talking, for example, about infant mortality, well, if you've got a country in which many of the births aren't even registered and the kid dies before he or she is a month old, then chances are you're going to underrepresent the degree of infant mortality in that country. And that's an important consideration. Obviously, you have outliers here of countries that are rich but still only register, have 60% complete registries. But you have a pretty important, now the other thing that's astonishing is that you have countries that are very poor that do really well. So you have huge heterogeneity, but obviously a strong relationship between income and completeness of at least those data, but this obviously extends far beyond that. And one other little point that we'll talk a little bit about how rich and how poor countries are, but obviously another really important issue is not just what the average wealth is of a country, but also how that wealth is distributed within the country, right? And I'm sure most of you have heard of the Gini coefficient, but for those of you that know it a little less well, the idea is that it's just a number to represent how unequal is the distribution of whatever, but in this case of income. But I'd like to think about also the unequal distribution of health in a country. And so what this is, if every person in a country had exactly the same salary, and you stack them all up in a line, and you just added cumulatively the salary of everybody in the country, you would have a straight line, because every additional person would contribute the same amount. But if instead you have a whole lot of people that make very little or have very little, then it would stay low for a long time until you got to the rich people, and then it would go up quickly. So the more that this curve is away from the straight line, the more unequal the distribution is. So it's like saying, another way to think about unequal distribution is what proportion of the total increase is captured by the top 10% of people, right? That's another measure of inequality. So you can imagine if you take the top 10% here, well, that represents all this increment, while the bottom 10% represent only this increment, right? So just important to think about that as we scroll through these countries, we've got issues of how rich or poor is a country, and also within the country, how equally or unequally is income distributed. And this is just a reminder for those of you, now this isn't complete because otherwise you'd have many more countries in color. It's not that white means zero, white means it's just not in this particular map that I grabbed. But Latin America is a hotbed of inequality. And within the high-income countries, the US is bright red, right? So we're the worst of the high-income countries, with the exception of a few states in the Arabian Peninsula or something, but of the big economies. And Latin America is a hotbed. I mean, South Africa and Brazil go back and forth for who of the important economies is the most unequal. So another little point, just to keep in mind. This is basically the same graph that I first showed you with those bubbles and the different countries, but it's made up data. Okay? And this is the same kind of relationship. Here you see that you have countries that go from $400 per capita per year to $40,000 per capita per year. This is a log scale. So 2 orders of magnitude difference between the poor countries and the rich countries. Okay? And here you go from 2 kids who die for every 1,000 to 20 to 200. Okay? So you have 2 orders of magnitude of difference in child mortality under 5 and 2 orders of magnitude of difference in income, with a strong relationship, as you saw in the real data just a minute ago, right? But this can be very deceiving. It's really good for economists who run regressions, right? Because this is a very robust line here. But it's just as robust as this one. So this is basically the same thing. 2 orders of magnitude, $400 to 40, and 2 orders of magnitude, 0.2 to 20. Okay? If this is all you look at, this looks just as bad as the previous one. But it isn't. Because we don't care about log people, we care about people. And that's a really important distinction. So what does that mean? It means that if I don't graph this on a log scale, this is what it looks like in real people. So this is, 180 people different. 180 extra deaths per every 1,000 births. And the second one looks like that. So the robustness of the relationship, child mortality is still just as related to income here, but in terms of how many deaths, how many kids die, this is negligible compared to the former one, right? So scale becomes really important, and how you look at these things becomes really important, because what we care about is reducing overall morbidity and mortality. Nobody's interrupted me yet. Okay, another cute picture. This is a map of our region. Regular. Which means that the size of each country is proportional to land area. That's the way we usually map things, right? But there's a clever app on the web called World Mapper, which allows you to pick any other or many other variables and adjust the map to the variable. Right? So I'm going to switch to that website. But what do you see here? What you see here is everything kind of shrinks with a few big changes. So Canada almost disappears because its population compared to land mass is tiny. Right? Mexico grows a little bit compared to the US. In the Caribbean, Hispaniola grows on both sides. Cuba grows, Jamaica grows, Puerto Rico grows. El Salvador grows the most. Nicaragua doesn't grow much. And Guatemala and Honduras grow a bit. And down here, everything pretty much shrinks. Some shrink a little bit more than others. And this is an artifact. Any idea why this is an artifact? This is a Latin American Studies group, right? It's France. So the way this map program works is it proportionally grows the entire country. So it grows French Guiana as much as France grows, and France is densely populated, right? So ignore that artifact bubble, because it in fact isn't the population of French Guiana, it's the population of all of France attributed to the land mass of French Guiana. So definitely a prize there. because I looked at it and looked at it and looked at it and says, what the hell? So this is Gapminder. So this is going back to that initial, I was going to show you the other one first. Oh, damn it, I closed it. So I'm going to go back and show it to you only here. Well, World Mapper is it. It's fun to play with because they get bigger and smaller, but I'm just going to show it to you here. So that's the population one that I just showed you. This is mapped by private health spending. Okay? And I suppose many people wouldn't be surprised by that because what is the huge change here? Well, really, it's just the US in the positive and Cuba in the negative. Right? Everything else, the relative size of the Andean states shrinks a bit, and Argentina is a little bit bigger. But the huge changes are Cuba and the US. And that's why? Well, because our health insurance is private, right? So we'd expect to see the opposite when it comes to public health expenditures. But it turns out that's not true. Turns out that we spend vast amounts of money publicly and vast amounts of money privately. So the US spends as much as the countries that spend the most in its public sector. And here's where you see France balloons up. And so I didn't notice it on the first map, really. But when this happened, I said, what? So you can see that that's a complete artifact of France. And there you can see that the private health expenditure in Cuba is tiny, but Cuba grows, relatively speaking, in the public. So one of the things, just to keep in the back of your head thinking about what the health looks like, is what we're spending to do something about it. Now, one important thing, and I'll show you in just a minute, is that this is very misleading. Because private health spending is really two kinds of spending. One is private out-of-pocket spending, when people are actually faced with an episode of illness, and they have to pay to resolve that episode of illness. And the other is private health spending where they buy private insurance, and therefore, when they have an episode of illness, the insurance pays for it. Both of those are captured here as private. And so in Mexico, for example, others of you can perhaps tell me more about other countries, but in Mexico, approximately 50% of all health expenditure is private out-of-pocket. So private health insurance is a very small piece. Public insurance is a big piece, and private out-of-pocket is a big piece, but private insurance is a small piece, which is very different than here. So here, I'm going to show you some stuff. So questions, comments? See, I've only been here 6 months, but I was told that Berkeley was this hotbed of radicalism. And I expected whenever I get up to talk, people would be throwing stuff at me.
You may be welcome in your quiet later on. So
this is a clever thing that you can also find on the web. The credit goes to a guy named Hans Rosling, who is a Swedish guy who was at the Karolinska, I'm pretty sure. I'm not sure about that. Swedish for sure. And then, of course, it was bought by Google. And now you can play with it. But just go to gapminder.org. And what you can do is you can play with the axes. So this is exactly the same graph I showed you a minute ago. And this is income on the bottom, and this is child mortality on the top. And this is 2012. So what I'm going to do here is just show you what happened over time. So 1800, everybody's up here around 400, which means 2 out of every 10 kids die before they hit 5 years old. And everybody's close to $400, $800. And then now you're up to the end of that century, and all of a sudden you can see countries are starting to get a whole lot better. The child mortality is falling quickly in some. Here you see India, China emerging. And now we get to 2012. Okay, and here's the US. Okay, yellow in this case these are not color-coded by region right now. They're color-coded by high income, upper middle income, lower middle income, and low income. If I switch that, I'd forgotten I did that. Switch it to geographic regions, you'll see this. And you can see here, Haiti, Brazil, Mexico, US, Canada. Down here, I'm not sure you can, nice thing about it is you can hover over any of these. But that's Cuba, of course. So Cuba is kind of cool because if you look here in child mortality, it's better than the US. And this is a law graph. So you're looking here at a PPP adjusted GDP of 10,000 compared to 42 for the US. So with a quarter of the PPP adjusted resources, they're doing better on child mortality than we are. And you can see that there's significant variability. This is the difference in wealth at approximately the same child mortality. And if we look, I'm going to show you a different one now. This is government health spending per person. So you can see that with the same child mortality. And you can see here, very similar relationship. And the surprising thing is that the US spends just as much as the richest. I mean, only the Nordics spend more than the US does in terms of public expenditures per person. And yet, child mortality here, we're talking about 7.6 for the US and countries down here that are between 2 and 3. So less than half of what the US gets. This is Japan here, the big red one. And here you can see what happens as this plays out over time. Oh. And I'll just play that again, but you can see the dramatic changes that China makes over that period. Now, if we go here, what I'm doing is showing you a very different situation. And here I'm just tracing out maternal mortality, same axis down here, this is maternal mortality. So while on the child mortality, we saw steadily declining, here we see one big exception, and that's that the US started up at about 1990. If we scroll this back, we can see that the US had its lowest point, actually 1978, and then was flat for a while, and then in 1990 or so, started climbing, so that we now have a maternal mortality rate that is 20, when the best ones, Ireland, Austria, are down at 4. And Albania, with a fraction of our GDP, is at 7. So, and here up above, you can see Mexico. Mexico hasn't done the rebound that the US has, but over that same period, it's actually stagnated. So Mexico is going to miss the Millennium Development Goals in maternal mortality. Now, why might these two things behave so differently? Infant mortality versus maternal mortality. Well, one reason that they might behave very differently is that infant mortality, or under 5 mortality, has had huge returns to major technological innovation. In particular, what do you think? You're typing very fast over there. What do you think is the major technological innovation that has most contributed to reductions in under 5 mortality? Vaccines. So vaccines and antibiotics, right? So vaccines to prevent these acute causes of death from occurring, and antibiotics to treat them when they do. And this is maternal mortality. And unfortunately, we don't have vaccines and we don't have antibiotics for maternal mortality. What you need is well-functioning health services, because these tend to be acute problems, and it depends on the performance of the management of the health services. So obviously there's some technological things that help, but like blood banks. But blood banks, I mean, when I was living in the Congo, which was then Zaire, we had blood banks. Now, when I lived in Colorado when I was in high school, I worked in the blood bank. We didn't have a blood bank in the refrigerator, we had a blood bank in the community, and when there was a problem, we called people in and they gave blood. And when my dad was that age, he gave blood person to person. So the technology for saving people from death from hemorrhage has been around for quite a while. It's the organization of the services to make it work. And so we can hypothesize about what's happening here in the US, but clearly it's bad for the bottom end of the income distribution that isn't getting the kind of care they need.
Is it related to like different methods of birth as well in terms of like C-sections becoming more popular in the United States or not?
Well, in most of the world, lack of availability of C-sections is a major contributor to maternal mortality, right? It turns out within Latin America, the US compared to some other high-income countries uses a lot of cesarean section. But compared to Latin America, it's incredibly low. I mean, Mexico and Brazil are extraordinary. I can't tell you about many other countries, but Mexico is extraordinary. I mean, when my wife happens to be an OBGYN, and we were in Cuernavaca and she was practicing, and I mean, the things that she'd hear, you know, women would be told that if you have your third child vaginally, everything just falls out. She went in to assist on a C-section with one of our colleagues, and the doctor said, you know, the Mexican women's body type isn't really made for having vaginal births. Or the cord is wrapped around the neck, it's an obligatory C-section. And the reason for this is that there are huge incentives for doctors not to sit up with a patient during labor and delivery, but just get them in, get the C-section, and get out, right? In this country, we see excessive use of C-sections because of the enormous financial incentives for the doctor. In Mexico, that's also true, but it's convenience in the public sector. There's financial incentives in the private sector. But I was amazed to see in the IMSS and the health services that provide the health services to the employed individual in the private sector, huge prevalence of C-sections. And it has to do with the fact that it's rude if you're a physician and leaving your shift to leave women in labor for the next person. You've got to like clean them out, right? So, you know, there is a potentially some role when you have the greatest excess, but in general, C-sections are very safe when they're done in competent hands. And it's more that, you know, if we looked here at, you know, if I showed you, for example, let's pick a really bad one. So, which probably doesn't have data, but here's Niger, here's Haiti. And you're talking about, I mean, we're talking here about 2. We're talking here about, this is 1,000, that's 500. Okay, so just extraordinary differences, right? And Haiti here is obviously in very bad shape. So, not every health condition is so easily related to income, though. If this is teeth. Turns out that bad teeth, income doesn't predict it very well. And you guys will have to tell me, I mean, traditions on sweets, early childhood feeding practices. I mean, this was a surprise for me, actually. Valdemar found this graph. And I was like, whoa, like, who would have guessed? China, India on teeth. Look at the variation here in this, the blue is Africa. So this is Central African Republic, the worst place to be from a health perspective. But, you know, even poorer or just as poor, you have Rwanda down here, which kills the US, right? As do a number of these places, Guinea-Bissau, Tanzania, Togo. So I can't explain this variability at all. I mean, within Asia, you have the Philippines, South Korea way up here, the US. So this one I don't have any good ideas about.
So what's the source of this data?
So of the data,
Yeah.
most of them, this one is, now, and of course the other question is it believable? So the ones I've been showing you have been a combination of World Bank economic data with a combination of WHO and the Institute for Health Metrics and Evaluation on the health data. In this case, and they usually say right down here at the bottom on the right, but this case it says various sources, and I can probably, you can open it up and go into it. This is, I'll play it for you. This is body mass index. And it's only from 1980. Now this turns out to be really important because of what I'm about to show you in a minute. But here you can see this is just a measure of how fat people are. And this is mean. So last year, Mexico overtook the US as the most obese country in the world. So we'd had that distinction for a long time, but we were just surpassed by Mexico. And at least one of the factors in Mexico is a huge proportion of the diet, of the calories in the diet, coming from sugar-sweetened beverages, which isn't that big a surprise if you've lived there, because we not recently had the president of Coca-Cola as our president of the country. So the fact that this is a country that likes its soda is not a great surprise. But why is this really important? Well, this is really important because it has some parallels to what I said before about maternal mortality. So the health consequences of this obesity are problems that don't have easy technological fixes. The great thing about a vaccine is that you can roll out a national vaccine program, and almost uncorrelated with income, you can vaccinate an entire country. So we may well in Mexico get rid, 20 years from now, of cervical cancer because of HPV vaccination, right? And the probability that you will have cervical cancer may well be largely unrelated to income. So what that will do will be to shrink dramatically the discrepancies. Now, if I go back for a second to the beginning one, and if I just remind you, this was under 5 mortality. But look at where we were in 1800. We were running between $400 and $1,000, or maybe $1,200, maybe even a couple that got up to $2,000. So let's say 5-fold difference between the richest and the poorest countries, and 2-fold or so difference between those with the highest and lowest mortality. As you move forward, what's happened? The 5-fold difference turned into, well, these countries are just as poor as they were in 1800. But now, instead of being 2,000, that 400 goes to 4,000, goes to 40,000. Right? So we've gone from 5-fold to 100-fold spread on income. And we've gone from up here at 500 to a spread that is still 2 orders of magnitude, but huge improvements in real terms. Comments, questions? Now what I want to do is to show you what the problems are. So this is people dying and people being sick, and where that's concentrated of all the things in this case that are communicable maternal neonatal diseases. You can see that concentration in Africa. One disadvantage of IHME, the Institute for Health Metrics and Evaluation. You can go to their website and play with this. The one disadvantage of this map for a Latin American studies group is that I can't change the color scale to focus on one region. So we'll see less variation here because there are places that are much worse elsewhere. So what is this? Well, this is Latin America. And what we can do is to pick any disease that we want, any year that we want. And in this case, it's 2005. And in this case, I'm just going to show you a couple of examples. That was all causes of disease. This is communicable diseases. So you can see here, where is it bad? Haiti, Guatemala, Guyana, Bolivia. The worst places to be if you're talking about communicable diseases. If you're talking about hepatitis, Not hepatitis. Let's go to cirrhosis. If we go to cirrhosis, what happens? Well, all of a sudden, Mexico jumps off the charts. And this is cirrhosis of the liver secondary to alcohol use. So Canada's way better off than we are. Colombia's pretty good. Uruguay, Paraguay, Andean states looks pretty good. The other one that's terrible is Guyana again. And so how does this look in a completely different way? Well, first let me just take the bottom one off. This is a pie chart. And this is a pie chart that is showing you in blue. I'll show it to you this way. One of the cool things you can do here is you can change the level of disaggregation. So the blue is all non-communicable diseases. The red is communicable, maternal, neonatal, and nutritional. The traditional diseases of poverty, the traditional diseases of wealth, and this is injuries. So if we increase it again, and I show you another one here, up on the top there is Canada, and on the bottom here I'll show you Niger. Oops, something bad happened. So Niger is about as bad as it gets, if you're a kid. So look at the difference in proportion. Remember the colors. This is diseases of wealth, diseases of poverty. This is lower respiratory. This is pneumonia in kids, largely in kids, also in adults, diarrhea, malaria. And up here you can see it's all ischemic heart disease, lung, these are the cancers, diabetes. Enormous differences from place to place. If we go from here to Guatemala, you can see that Guatemala is in between Niger and Canada. And if we go to Mexico, neighbor, now one other thing that's really important on this. Remember the graphs we saw before with everything's getting better over time, right? Everything's getting healthier and healthier over time, except here what you're seeing is that that's not true. Because the color of each of these boxes is whether it's getting better or worse. So what's happening in Mexico? Mexico still has residual diseases of poverty, and it has 20% of the population that's really poor. But these are all really light, right? The pneumonia, the diarrhea, the preterm birth, the neonatal encephalitis, the neonatal infections are all getting better. TB is the exception there. And this is Canada, right? And here you see lower respiratory infections getting worse. That's probably because of the aging of the Canadian population. That's probably old people's pneumonia. Here, though, you see this dark blue swath in the middle. That's the result of the obesity that we just saw in the previous graph, right? So what's this going to mean? If the healthcare system, which struggles to deal with things that don't have quick technological fixes, if it struggles to deal with maternal mortality, you can imagine how it struggles to deal with diabetes. I mean, when I was in Mexico, the best healthcare system, the IMSS, published one study that showed that it didn't matter how many times you went to see the doctor for your diabetes over the course of the year. That didn't predict how well controlled your blood sugar was. So major problems in the healthcare system that was very successful and continues to be very successful at lowering these causes of acute illness among kids, at dealing with these chronic problems. This is heart disease, stroke, diabetes, this is kidney disease, diabetic kidney disease, hypertensive kidney disease. So this means that the pattern that we're also seeing in California, where these diseases are dominating, is what's happening in Latin America. But to very differential degrees. So if you look at the shape of those colors, what's dark and what's light, this is Peru. You might not think of Peru being that different from Mexico. It's radically different. I'm just going to show you a couple of things, and then I'm going to stop. I'm just going to come back for a second and race through a couple of things here. Well, let me just tell you, I'll just tell you one quick thing about what it is that we're measuring. So all those boxes that I just showed you, they're measuring disability-adjusted life years. What is a disability-adjusted life year? It's a combination of people dying and people being disabled, right? So this is, if you had a life expectancy of 78 and you lived in perfect health and you were 78 and then you got hit by a bus, this is what you would lose no DALYs relative to the expected number of DALYs that you would live if you were healthy till you were 78, right? But if instead you get hit by a bus at 60, then you lose 18 DALYs because you lose the full amount for those 18 years, right? So you lose 18. But if you lose your left arm when you're 20, and if not having a left arm is 75% as good as having everything, then that means that you lose 10 DALYs for the years that you live from 20 until you get hit by a bus at 60. So what these measures do is that they assign to every health state that is not death a level of disability. And we could talk for hours about how good and bad those estimates are. But that's what these things are doing that I just showed you. They're combining morbidity, meaning less than death but still not fully well, with mortality, which is why you see things like major depressive disorders being so important in this country. Because we're running out of time, these are some regressions that Valdemar was playing with, and I just want to show you a couple of things here. This is diabetes, because the nice thing is that pulling out of the IHME data that we were just looking at, it's more disaggregated than the earlier bubble chart data. And here you can see 3 years worth. So you've got 2000, 2005, and 2010 for a few countries. How many countries total? Is it 8? 7. So we have the Dominican Republic, we have Mexico, Uruguay, Argentina, Peru, Ecuador, and Colombia. You don't see, if you took Mexico out of this, it wouldn't be very convincing, right? So there's a line there, but it's really driven by Mexico. So Mexico's an outlier so far in diabetes and its complications, as well as cirrhosis due to alcohol. This is under 5 mortality. And here you can also see what's happening within a country, right? So this is over 15 years, what's happened in GDP in Mexico, and what's happened in under 5 mortality. Remarkably successful, Mexico, at reducing under 5 mortality, right? This is during oportunidades and doesn't really capture yet Seguro Popular. Here you can see Colombia, similar kind of trajectory. Dominican Republic, similar kind of trajectory. Uruguay, not quite as good. I don't see where the other one is. It did very well, I think, in the first period, and then it stalled. No, it did very well in the second period and was stalled initially. This one is interpersonal violence. And the relationship here is interesting. So this is Gini. So this is looking at interpersonal violence, not against how wealthy the country is, but how unequal it is. And that is a striking relationship, I think. So this is not suicide, this is not accidental death, this is not road death, this is one person hurting another person. And here you can see also some trajectories over time. So this is Mexico 2010, 2005, 2000. Here you can see the 3 Perus. Argentina here.
Mexico is actually an outlier, no?
Mexico's an outlier.
Equality, they're more equal and more violent, actually, or same level of violence. Probably the drug war cartels mentioned.
Exactly. It's probably an independent factor. It's the explanatory factor in Mexico is more like the explanatory factor for sugar-sweetened beverages. Pobre México, tan lejos de Dios, tan cerca de los Estados Unidos. This is, I thought, one of the ones that I thought was most interesting. And we did a study in Mexico. I didn't actually do it. Paul Gertler up at Haas was the evaluator of it. But it was a program done by the Ministry of Social Welfare, I guess it translates, which was called piso firme, which means hard floors. And what it did was it subsidized putting in concrete floors in low-income households that had dirt floors. And it showed dramatic benefits in terms of reduction of diarrheal-related illnesses. More amoeba than anything else, actually. So this may be just urbanization, or it may be a proxy for cement floors, and some mix of those two. But the relationship between urbanization and diarrhea is really striking. And of course, lots of other things. I mean, socioeconomic development is associated with urbanization and everything else. But there is some degree of variation even within the countries. And I think that's it. Oh no, well, it's not completely it, of course, but I'll stop there. These are similar kinds of graphs, but let me just make the final point, though, is that while we have increasing socioeconomic inequity between countries, we have dramatic convergence in health. In other words, inequality in health over the last 50 years, 100 years, has been not 200 years, because we were all the same and horrible 200 years ago. Then we spread apart. But as we got richer, technology came in and dramatically reduced the differences between countries. And that, I think, the exception to that was AIDS in Africa. So this is adults dying between 45 and 60. This is Africa coming down like everything else and then shooting up. But if you look at Latin America here, we're all coming down and we're converging. So that's an important message. But I worry, given what I've said about diabetes and maternal mortality, that unlike Moore's law, we can keep making the chips smaller and putting more transistors on a chip. There's a limit to what we can do with technology for diseases like that we can solve with vaccines. And we're getting into the area where it's personal behavior, it's choices like obesity, and it's the performance of the healthcare system that are going to be determinants. And that won't be as easy to converge as what we've seen so far.
Just another point, do you think taxation is a health intervention that you could tax fat?
It was interesting that you were, because I definitely think that taxation can be a health intervention to the extent that it reduces inequity and provides access to services, but that's not what you meant.
No, well, you can do that as well. But you can also tax eating certain types of food.
So that's exactly what Bloomberg is doing in New York, right? And that's what Mexico has decided to do with sugar-sweetened beverages. And it's what we have done for a very long time in this country with tobacco products. So absolutely. And we can have a raging debate about what the effects of those taxes are on poverty. But I think that if you structure the tax in a way where you are disincentivizing the consumption of the harmful thing, whatever it is, and making sure that those taxes are then used in a way that does not disadvantage the people who disproportionately pay them, who are poor people, then you can have a socially beneficial intervention.
Also, one of the important factors that having an important effect on the healthcare of the Americans is the very quick demographic transition that many of the countries are going through. For example, Mexico have a lower child birth rate than the United States last year, which is interesting in itself.
So if I switch this, I thought it was here, but maybe it's in health. Did I just miss it? Where is it? Oh, there it is. Total fertility. Come on, Air Bears. So this is total fertility, children per woman. And that's the US over here. And China. Japan now, plummeting. China falling precipitously. India falling. And you can see what's happening here. Latin America is now all down here. Brazil, Mexico. And the U.S. has lots of immigration, so it changes the population figures a bit. But you're exactly right. This is an incredibly dramatic difference, right? And look where we are here in Niger. We're at 7.5 kids. Well, we're below replacement rates. You know, it's 2.1, 2.2 that's replacement. So all these countries down here are below replacement. It's astonishing. And the figures that you see, if you go back to something like this, and if I went to all cause, so you would expect with all cause that Canada would be the best, right? Or maybe you might expect that. So 24 for Canada, and instead you have 22 for Mexico. So why is that? Well, it's just the age pattern of the population, right? So you've got a lot of older, sicker people in Canada with performance of the health system that's not bad. So the actual total burden of disease per person is actually lower in Mexico than it is in Canada. And that's exactly due to what you're saying. Mexico will catch up.
Very fast.
What do we do with the black holes? The places where the health conditions are probably at worse. And there are almost no statistics because there's no access, very little access to health care. Or where case definitions might require laboratory confirmation and no laboratories. So indigenous areas, many rural areas, we want to be able to write them into this vast presentation of data, but they're really asked to let out just by taking these sorts of normally produced statistical measures. How could we just sort of bring them back into a picture, which I think, if we're talking about the outer limit, the worst case scenarios, we probably want them into this larger picture.
So that's why at the very beginning I showed that income related to civil registry, just to make exactly that point. We've gotten so much better in the time that I've been working in public health addressing those issues. So just as one example, the U.S. government supports something called the demographic and health surveys, which go to a huge number of very poor countries, and they do a full population-based representative sample. Now, they started off focusing mostly on family planning, but they've become pretty comprehensive health surveys, including, since my area is HIV, including in many countries what they call DHS pluses, where they actually test for HIV infection. Now, you know, in countries in Latin America, the problem that you're identifying is much less true, because you'd expect it to be most true in Haiti, but Haiti has a huge amount of international donor support, so things like DHSs get done in Haiti. I mean, it's highly variable, and within country, I mean, I can speak for Mexico because my center used to run the national health surveys. We would oversample areas to make sure that we had good indigenous samples and rural samples, et cetera. But Mexico's an upper middle income country. It has very, very poor populations within it. But I think in terms of the national statistics are actually reasonably good. I mean, we even got into bad drug areas as long as we would agree not to ask about what was being produced in the fields and things of that sort. But that doesn't mean that we couldn't get height and weight measures on kids and adults. I think that for some things where you rely on a reporting system, you can just ignore the data because they're worthless, right? So a perfect example of that is syphilis, right? So first of all, people treat themselves at the corner drugstore. Secondly, a tiny proportion of physicians report syphilis when they actually treat it. And thirdly, the most important determinant of the amount of syphilis they report is whether physicians have what kinds of incentives to report rather than what the actual prevalence is. So it's highly variable. I mean, I think that one of the biggest problems is looking at issues like infant mortality, but even there the measures have gotten a whole lot better. So folks like the folks that produce this, which is out of the University of Washington, what they do is they field surveys on verbal autopsies to try to get at exactly some of those kinds of issues. Now, the verbal autopsy is pretty good at identifying that there was a neonatal death, it's much less good at identifying the cause of that neonatal death, right? And there's when IHME came out with these numbers on malaria, they're radically different from WHO's numbers, because IHME finds a lot of adult deaths due to malaria, which WHO does not. And so, it's a lot of that is a question of attribution within the envelope.
What interventions or programs do you think might have the best potential ability to curb rises in obesity and diabetes in Latin America?
I'll take the second one first, which is easier, and that's diabetes rather than the obesity. I think the biggest difference between the diseases that we've been so successful with, like the diseases of poverty in Mexico and actually throughout the continent, is that we were able to come in with vertical programs, do things to entire populations, whether it's improving the water supply or vaccinating kids or whatever, and improving health conditions. You can do that with a very patriarchal, very disrespectful healthcare system. You can't do that for diabetes. Diabetes requires a partnership between the provider and the patient. It requires an empowered, participatory patient to control that over a lifetime. We don't have those healthcare systems. I mean, I was talking to Valdemar yesterday about experiences in the healthcare system. We complain a lot about our health care system here, but what happened over probably the 70s was the biggest point of inflection, was empowerment of the patient. And that, I think, is the only approach to hypertension, diabetes, HIV, diseases that require a lifetime of careful attention. For dealing with obesity, all I can say is that this is not the country to lecture anybody about obesity. And the causes are, one thing that's really interesting with Mexico, and the reason I mentioned sugar-sweetened beverages, is that in this country the biggest problem is fast food. So here the biggest problem is it costs you less to go to McDonald's than it does to go to the supermarket, buy the food and cook it for yourself. So that creates enormous incentives for the bottom end of the socioeconomic distribution to eat horrible food. Right? In Mexico, that's not the case. In Mexico, McDonald's is still a very middle class. It's in the good malls. You don't find, and if you're eating commercially prepared food in Mexico, you're eating much healthier food if you're lower end of the socioeconomic distribution or the upper end of the socioeconomic distribution. But what's not true is snack foods. So the potato chip, enormous variety that you find in any tiendita in Mexico, and soft drinks. So the sinners, but what's interesting though is that in both places, it's the industry between the harvest and the mouth that is creating a major problem. So I think one major part of the answer is that what we did in this country and elsewhere with the tobacco industry, we have to start doing with the industry that's poisoning us. I mean, I don't know if it'll work, but I'll... I don't think it's going to work. Oh, yeah, it is. Sorry. Oh. Oh. This is my childhood. Most of you are too young. school with this guy's kid. And I grew up in Colorado. So this was like America. This is who you wanted to be. This was resilience. This was strength. This was fabulous. And it's Christmas. And you're proud and you want to be like this guy. So we stop those. But
And Virginia's lens has taken up the mantle. Making it sexy again.
ay, ¿cómo se llama el otro?
I know they feature them in a series with graphic characters.
Well, I probably don't need to convince you, but
Para los gordos, para los flacos, para los altos, para los bajos, para los que ríen, para los miopes, para los que lloran, para los optimistas, para los pesimistas, para los que lo tienen todo, para los que no tienen nada, para los abiertos, para los que juegan, para los cerrados, para las familias, para los ansiosos, para los reyes, para los magos, para los comprometidos, para los náufragos, para los rockeros, para los que van en tren, para los educados, para los que sufren, para los motociclistas, para los de allá, para los que trabajan, para los de acá, para los románticos, para los que te quieren, para los que no te quieren, para los que te quieren mucho, para los que te quieren poco, para los bronceados, para los nudistas, para los supersticiosos, para los originales, para los malabaristas, para los calculadores, para los pelados, para los deportistas, para los que leen, para los que escriben, para los astronautas, para los gemelos, para los distintos, para los payasos, para los que viven solos, para los que viven juntos, para los cuenteros, para los que besan, para los primeros, para los últimos, para los hombres, para los precavidos, para ella, para los músicos, para los transparentes, para los fuertes, para los que se superan, para los que participan, para los que suman, para los que no se callan, para nosotros, para todos.
we watch those nowadays. Christmas, I could show you another one that I saw at Christmas in Mexico. That's normal today. That's the biggest cause of death and disability in Mexico. It's completely acceptable, socially acceptable. When the Marlboro ad is an anathema now, right? That's like horrible. Think about what they used to do to us. I have here,
Is that out of Mexico?
no, the one I just, very much Argentina. This is a picture which you can't see, but it's a picture of our chancellor standing in the athletic center in front of the Pepsi-sponsored athletic complex. So until we turn some of the muscle that we've previously turned on our tobacco to what certain parts of the food industry are doing to our health, and even worse, the health in developing countries, then so that's my long answer to the obesity question. Right.
I have a question about a different beverage, drinking water, and public health. Which countries in Latin America, excluding the Caribbean, do you think have made the best advances in clean, accessible drinking water in the past?
So the easy answer is I don't know. But one other cool thing on this thing here, oh actually probably. So this is a chart of risk factors, but it's probably better if I show you just one. So sanitation is here, unimproved water is here. This is dietary risks. So if I showed you that's Somalia. So it just shows you how extraordinarily different countries are. Unimproved water is here. This is suboptimal breastfeeding. So the best way to to protect your kids against unimproved water is to not give them any for 6 months, right? And that's one major problem. I mean, a huge number of places that colostrum, the first milk that comes out, is felt to be somehow bad. So what do you do to that brand newborn kid is you feed him this water, right? So this is household air pollution from burning fuels in the house without adequate ventilation, and this is childhood underweight. So if we go to among the worst in Latin America, and I showed you Guatemala, it'd be a mixed picture, but still pretty bad. But look here, unimproved water is down here. So unimproved water in Latin America, with the exception of Haiti and the cholera epidemic, which is off the chart, isn't really a big problem. I mean, in Guatemala, breastfeeding is still a major attributable risk. Childhood underweight also significant, and the top one here is alcohol.
Unfortunately,
We're out of time.
we're out of time. I'd like to thank everyone and then to thank Dean McCovey for being with us.